So AFLP is nothing but acute fatty liver of the pregnancy. So in AFLP, it is a microvascular steatosis of the liver, and the risk factors for the AFLP are, we have preeclampsia, LCAT deficiency, and male fetus, previous history of the AFLP, and the low BMI of less than 20 kg per meter square. And also there's drugs like acetyl salicylic acid, which inhibits the oxidation of the long chain fatty acids, leading to the increased risk of AFLP. And so in LCAT deficiency, it is an autosomal recessive inheritance. Usually the mothers are heterozygous and the fetus are homozygous. So there's a inhibition of the beta oxidation of the long chain fatty acids because of the LCAT deficiency in the fetus, leading to the accumulation of the long chain fatty acids. These will re-enter the maternal circulation and exhaust the beta oxidation enzymes in the mother, leading to the AFLP. So this AFLP induced pancreatitis, leading to the increased serum amylase and the lipase. And also there's a increased placental disruption, leading to the hypoxemic injury to the fetus. And also there's a detoxifying function of the liver is also reduced, leading to the decreased downstream production of the blood coagulation factors or antithrombin 3 or fibrinogen. These are also reduced. So the patients will have nausea, vomiting, fever, malaise. There can also be a liver failure with the hepatic encephalopathy, and there's increased leukocytosis, and there's increased serum amylase and the lipase, and also renal function is affected, leading to the ARF, leading to the increased serum urea, creatinine, and the uric acid, and increased hyperbilirubinemia. Okay, and the DDs of the AFLP are acetaminophen-induced toxicity or drug-induced hepatotoxicity or eclampsia or HELP. Next, we have a criteria called Swansea criteria for AFLP, where 14 clinical, pathological, and the radiological factors are considered, of which 6 factors has to be present for the positive criteria. So the clinical factors include vomiting, abdominal pain or abdominal discomfort, polyuria, polydipsia, or encephalopathy. And the pathological factors are, we have total bill of more than 0.8 mg per deciliter, and the urea of more than 5.7, creat of more than 1.7, and urea of more than 47 ammonia. Okay, so you'll have vomiting, abdominal pain or abdominal discomfort. You'll have polyuria or the polydipsia. Next you'll have is encephalopathy. You'll have total bill of more than 0.8 mg per deciliter. Elevated transaminazole of more than 42 international units per liter. RBS of less than 72, that is hypoglycemia because of decreased gluconeogenesis. And creat of more than 1.7, ammonia of more than 47, urea of more than 5.7. Next, urea of more than 5.7. Next you'll have is elevated TLC of more than 11,000. Next you'll have is coagulopathy, that is PT, and the APTT of more than 14 and 34 seconds. Next you'll have is histological features like ascites, and you'll have ultrasonic features like bright appearing liver, and histological features like microvascular steatosis of the liver on the biopsy. So management, you have to go for the critical care support, you have to go for the high carb diet, and also you have to check every 6 to 8 hours. You have to check for the RBS and maintain more than 62, and you also check 6 to 8 hourly coagulopathy, that is PT, and the APTT. And you have to continue the FHR monitoring, MGS for less than 32 weeks for the neuroprotective activity, and you have to go for the IUL if the delivery is expected within 24 hours, and if not, you can go for the C-section. And you have to avoid halothane, as it is a hepatotoxic drugs, and you can go for the GA in case there's coagulopathy. If there's no coagulopathy, you can go for regional anesthesia. and usually you have to go for the LFT, KFT after the delivery or after the C-section, and in the newborn you have to check for the LCAT deficiency as there's increased reoccurrence rate. Okay, reoccurrence rate. So for the women who developed AFLP in the third trimester, in the next pregnancy, you have to be more vigilant about her, and you have to repeat the LFT or coagulation profile in the first trimester, and also in the second trimester, also in the third trimester. This way, you can early identify the features of the AFLP and helps in the timely intervention.